I'm going to talk with you about TB and the latent drug therapy. If a person converts to positive, as that means that they have antibodies to TB, for the first time they would be treated with isoniazid for 6 to 9 months. By 6 months if they have no immune compromise, but for 9 months if they have immune compromise status. So active drug therapy for active TB would be, initial phase would include 4 drugs for 2 months, and the 4 drugs would be isoniazid, rifampin, pyrazinamide, and ethambutol. INH, which is isoniazid, is a medication that can cause liver enzymes to rise and also can cause hepatitis. Rifampin is a medication that can cause orange discoloration of body fluids such as saliva, urine, etc. Can also cause hepatitis. Pyrazinamide is a medication that can cause hepatitis, arthralgias, and hyperuricemia, which means elevated levels of uric acid, leading to potentially having gout. And ethambutol can affect the person's visual status. It can cause ocular toxicity, and they can have decreased red-green discrimination. So prior to initiating this treatment, the patient would have, of course, liver enzymes drawn and also have a visual test to determine their visual acuity and their red-green discrimination ability. That way it could be tracked while they were receiving the medications. Remember that one of the key problems is that people don't continue taking their medications for the whole time, and this means that they have a risk for drug resistance. So they're going to have these 4 drugs for 2 months, then INH and rifampin for an additional 18 weeks or longer. It could certainly be longer than that. If the patient has a drug-resistant variety, they're going to add a fluoroquinolone, and they might have a second-line treatment after the initial treatment, or they could have adjustments in what they take. Patient education, we want our patients to know what to expect with these medications and the importance of taking them even after they start to feel better. We want them to know when to call in for problems. For example, what would be hepatitis symptoms, and also visual changes and any other problems, and when to seek 911 help or go to the ER. We really want to stress the importance of compliance. It's crucial for public health that the patient takes these medications. And as I said, liver function and vision would be monitored. So DOT is directly observed therapy, where a public health nurse will go to a patient's home and bring the medication, watch them take the medication, and check their mouth afterwards for having swallowed the medication. And this is how serious it can be, that it goes to this extreme. There certainly is a strain on public health departments when they have a lot of people or even a few people that need DOT. But if there's suspected non-compliance, this is a major component in drug resistance. So this is done while the person is in active TB, and it may be done for even longer. In fact, I've seen it when the public health department called the police on a homeless patient who was not taking the medications, and they actually arrested this person and kept them in custody for them to take their medications. TB treatment, the goals are that they comply with therapeutic regimen, take all of their medications for the entire time, and have no recurrence of the disease, and don't transmit the disease to anyone else. TB can be cured. It can completely resolve with the correct medication regimen. And we also want this person to have no pulmonary scarring or decreased function. Sometimes that depends on how long they've had TB, but they should be free of TB by the end of the treatment. So complications are miliary TB, where it disseminates throughout their body pleural effusion is potential pneumonia and other organ involvement such as the CNS, bones or joints, kidneys, adrenals, lymph glands, or genital tract can also have TB. So now we're going to switch to pulmonary embolism. This is the blockage of the pulmonary artery by a thrombus. It could be a thrombus or it could be an embolism, like for example with fat embolism. So it causes AFib or DVT or fat emboli are the main causes. Risk factors: immobility, surgery, stroke, history of DVT, hypertension, or obesity are all risk factors. Certainly when you throw a few of those risk factors together, you have an increased potentiation. Clinical manifestations: sudden onset of these. Dyspnea, chest pain, hemoptysis, so coughing up blood. It may begin suddenly. If it's a large pulmonary embolism that's obstructed greater than 50%, it can cause right heart failure because of pulmonary hypertension. So the blood's not able to proceed forward because of the obstruction, and it causes increased pressure in the pulmonary artery. It can also lead to severe hypoxemia and decreased blood pressure. Diagnostic tests for pulmonary embolism are going to be a spiral CT with IV contrast, or they could also have a VQ scan, venous quotient scan, which just shows an indication that it's positive for PE. The D-dimer is a test that shows the breakdown of fibrin degradation products. Shows a breakdown of clots. In other words, fibrin degradation products from a clot. So that also is an indication. It's not a diagnostic yes or no, but if they have a high D-dimer and symptoms and CT evidence, then that would be contributory evidence. They could have a pulmonary angiogram. This is similar to what we talked about with the leg angiogram, but this time they would go in the femoral vein usually because they're looking at the pulmonary side, so they're going to go venous. I'm going to go up and look with a catheter and look at pressures and see what blood flow is going through the pulmonary system by injecting contrast in the blood. Also, ABG certainly would be ordered to see how the person's tolerating this situation. Treatment would be with anticoagulants. We could use TPA to go in and actively break down the clot. As you know, with TPA, there's inclusion and exclusion criteria because it can be have very serious consequences if we break down clots that are important for the person to have. The other alternate approach is usually heparin drip to prevent more clots from forming, and it could be Lovenox. It depends on how serious the PE is, and putting the person on Coumadin or some other like Xarelto anticoagulant to prevent clots while the body breaks down its own clots. So either actively break them down or prevent clots while the body breaks it down are two potential roads there with medications. And then supportive care, certainly if the person has a huge PE like you see here, where it's blocking a whole side here, that person might need intubation support or more invasive oxygenation help. In this situation where the person has multiple blockages, they also could show hypoxemia and severe problems with organ perfusion, so supporting them. Obviously, prevention is the key. When I was a new nurse, we had heparin drips all over the place, left and right. People were constantly coming in with DVTs or developing DVTs, and now we have a pretty good program to prevent DVTs, which is one of the main causes of pulmonary embolisms. So, and also don't forget about the IVC filter as being a preventative part of treatment, if possible, if it's known in advance or high risk. So pulmonary hypertension, this is high blood pressure in the pulmonary artery. So you see up on this, I think I added this to your slideshow. So here's your right atrium, here's your right ventricle, and here's your pulmonary artery. So it would be high blood pressure in this area. It can be due to an idiopathic, so genetically caused from some narrowing in this area or problems with this valve, or it could be unknown. The cause could be unknown. A secondary would be the result of another disease process, such as a person who has chronic hypoxia. As we know, hypoxia will cause vasoconstriction, because if you think about what the body does when there is hypoxia, with low blood pressure, we try to vasoconstrict to improve perfusion downstream. That is also what the pulmonary artery does. If there's body hypoxia, pulmonary artery will vasoconstrict, and this causes increased pressure in the pulmonary artery. And this could be a person who's consistently has hypoxia, so they might have COPD, atherosclerosis, PE, or other things. The problem with this pulmonary hypertension is that it makes this right side of the heart work a lot harder. So you can get hypertrophy of these cardiac muscles, and then that means that they need more oxygen flow to it. So if you're having high blood pressure and having trouble pushing into the system, you're going to have decreased cardiac output, or that's the risk of having decreased cardiac output, which means that the coronary arteries are not going to be perfused well, which means that this hard-working muscle may not get the oxygen that it needs to function well. And then also, if you're having trouble pushing into the pulmonary artery system, you can have a fluid backup in the right ventricle through the right atrium into the venous system, and causing a general fluid overload picture. So signs and symptoms of pulmonary hypertension, they might be very subtle at first, but dyspnea on exertion. So in this picture, this person who needs increased O2 when they're active, say walking or doing some kind of work, can't get it because of the inability of the right side of the heart to push blood through that hypertensive pulmonary artery. So that leads to dyspnea on exertion and also a general fatigue. So treatment can extend life, but we haven't found a cure for this. Some medications, and I don't need you to know exactly what, that's really critical care area for studying the medications and how they promote pulmonary artery vasodilations. But you may care for people who are walking around with a continuous infusion pump of a medication to promote pulmonary artery vasodilation. It doesn't mean that they always need to go into critical care like ICU whenever they have any kind of procedure done. They can be on med-surg with this pump going. So just know that may happen, but preventing hypoxia in this person is going to be one of the key parts of treatment, because the more hypoxic they are, the more they're going to be have their pulmonary artery hypertensive. So using diuretics or anticoagulants, calcium channel blockers, and O2 to decrease their symptoms is another line of approach. And then this person may need a lung transplant. Without treatment, this pulmonary hypertension can lead to cor pulmonale, which is right side of heart failure. If you get right side of heart failure where it just can't pump out, of course you're going to get left side of heart failure following that, and the person will likely die. Pulmonary edema is another aspect of the pulmonary problems, pulmonary disorders. And this is caused by abnormal accumulation of fluid in lung tissue as a result of other diseases. So this isn't pneumonia because it's not infected at this point. It can happen quite rapidly, such as flash pulmonary edema, refers to a sudden onset. And this is frequently what I see is the sudden onset of pulmonary edema. And what happens is because of the fluid in the alveoli, you get a refractory hypoxemia. And what do I mean by refractory? That means that when they're hypoxemic and you apply oxygen, it doesn't change, it still remains hypoxemic. And you apply more oxygen and it's still hypoxemic. So that's refractory, non-responsive to treatment. So this, the most common causes are heart failure, where the person becomes fluid overloaded suddenly, fluid backs up from the left ventricle into the pulmonary bed, and they are unable to oxygenate. Other causes could be COPD exacerbation or near drowning and other reasons. Key signs and symptoms, because the fluid back, like you know how the capillary and the alveoli are very close here with just one lining of cell between them, and there's interstitial area. What happens is the fluid pressure in the capillary from fluid buildup back up becomes higher, and fluid leaks out of the bloodstream into the interstitial area and then into the alveoli, and it can be blood tinged because it's leaking out of the capillary. So that's why the person gets the pink frothy sputum. That's a key indicator. If you ever see that on a test, whether it's my test or Linda's test in 4th semester or the NCLEX, pink frothy sputum is an indication of pulmonary edema. So especially in the light of refractory hypoxemia with sudden severe dyspnea. In other words, they're very symptomatic. Their O2 sat is very low. They have pink frothy sputum. This is pulmonary edema. That's what it looks like. So treatment is going to have to be related to the cause. If it's heart failure, you'll learn about those treatments more next semester. But oxygenation support, diuretics to take some fluid off, cardiac meds if it's a cardiac cause. Pulmonary fibrosis is when the lungs are scarred by connective tissue, and this comes about because there's, just like we learned about in the liver, when there is repeated inflammatory effect, the repeated episodes of inflammation that causes fibrotic changes. And if there's scarring like this in the alveoli, I mean, this is a severe instance, but many people do have some pulmonary fibrosis, and it causes the lungs to be more stiff so that they can't expand and contract and adapt to the breathing process. And that means that if they can't expand, they can't get oxygen in to diffuse across the alveolar membrane, neither can they get CO2 back. So some of the causes are inflammation, which is smoking is the #1 cause, because there are like 1,500 different carcinogenic chemicals in smoke that irritate the lungs. Also occupational exposure, excuse me, to any kind of irritant to the lungs, or environmental exposures such as asbestos can cause this, or different indoor chemicals that a person might be exposed to, or through the cause of construction, being exposed to dust in work. Also, people that work in agriculture can inhale a lot of environmental irritants and other problems. So this constant irritation to the lungs can cause fibrosis. So prevent when possible, have people wear masks to protect their lungs. Symptoms are severe dyspnea and dry cough. Treatment would be steroids, respiratory medications, or cytotoxic drugs. And the prognosis is not good for people with pulmonary fibrosis. They may need a lung transplant. There's not a lot that we can do other than supporting them oxygenation-wise to help with that. And then pneumothorax. This pneumothorax is a complete or partial collapse of the lung. Excuse me. It could be spontaneous, and what happens with spontaneous, it occurs in people without any underlying lung disease usually, and in the absence of an inciting event. So it's commonly, or most commonly, seen in tall young men between the ages of 10 and 30 years. It's rarely seen in older people older than 40 years. We don't know why it happens, or it's unknown, but ruptured alveoli are theorized to be the cause. But people may have a genetic predisposition to this, such as people with Marfan syndrome. Also, people that are cigarette smokers have an increased risk. Secondary spontaneous pneumothorax can occur in people that have a lot of variety of lung diseases, such as TB, sarcoidosis, cystic fibrosis, or cancer. So I should have started out by saying spontaneous would be a closed, means that the lung or the thoracic cavity is not open to air. So there's no puncture in the wound, versus an open, which is traumatic. Pneumothorax is a complete or partial collapse of the lung. It could be spontaneous, which means that it happens without any prior warning. It could be a primary spontaneous, which might occur in people without any disease process, or it could be a secondary spontaneous, which would occur as a result of another problem, such as another lung disease. A primary spontaneous, this can occur especially in young men between the ages of 10 and 30. They may have a genetic predisposition, such as Marfan syndrome. It's more likely to occur in people who smoke than people who do not smoke. And secondary spontaneous, occurring as a result of another disease process going on, such as emphysema, TB, cystic fibrosis, cancer, etc. Sometimes we don't know the cause of it. That could be idiopathic, so unknown. And then iatrogenic is the same as like nosocomial, except that it's caused by something that happens as a result of medical or surgical procedures. So the most common reason for iatrogenic pneumothorax would be a biopsy of the lung or the nearby area, and like a CT guided biopsy where they put the person in the CT machine and they go in with a needle and take a piece of lung tissue for biopsy. And probably 30% of those people end up with a small pneumothorax, rarely needing anything more like a chest tube, but they may be watched overnight to be sure it doesn't expand. Also, thoracentesis has a pneumothorax risk for iatrogenic. Traumatic, open or closed, is usually caused by some kind of wound of the thoracic cage or underlying pleura. Typically, a thoracic wound might cause a rib fracture that punctures the pleural membrane, so that might be the reason it may open to air the lungs, which will then collapse due to the pressure, increased pressure of the atmosphere versus the pressure inside the lung. And a tension pneumothorax is when there's an escalating buildup of air in the pleural cavity. So outside of the lung, a buildup of air, kind of what you see here with blood. If air builds up in this pleural space, it can cause this lung to collapse or to be compressed down so that the person is not able to oxygenate as well. And pleural tension pneumothorax can occur with air, and then you can also have like a hemothorax where it occurs because of blood being in this area. So that person would need a chest tube, and you're going to learn more about chest tubes in Linda's class. Clinical signs and symptoms of respiratory distress. Depending on what is the cause, it may occur rapidly, or it may be a slow occurring thing, such as if there's a leak in a blood vessel over here for some reason. It's a small leak, it might occur slowly. So what needs to happen with the pneumothorax is that the person gets a chest tube, and that lung is allowed to re-expand and to heal. And that's what a chest tube does. All right, thank you all. See you in class. Bye.